So, with the permission of my faculties and all the delegates who have joined, so I'm starting today's session. So, good evening, all of you. I hope you are all doing great in this new year. And myself, just to for the introduction purpose, I will be starting. Yeah. So myself, Dr. Tapas Kumar Sahoo. If anybody doesn't know me, so I am uh, heading the critical care at Medanta Hospital, Ranchi, and somewhere or other I am related to the training part of the European Diploma in Intensive Care for last couple of years. Previously, I was the International Asia Pacific representative to ESICM, and also I am trying to have a structured approach to the different exams, including the EDIC 1, EDIC 2, as well as the DRNB and DM. So along with me, my Dr. Sananta Kumar Das, as well as Dr. K. Swarna Deepak, who are associated with me for a long time. So we are trying to have something good for the trainees who are appearing the EDIC 1 as well as EDIC 2. So with this background, I know everybody who is here today doing critical care at different parts of the country as well as the world. So they are brilliant. They have done their training. They have done the education part very well. But yes, today we are discussing about a special exam, that is EDIC 1 and EDIC 2. And specifically it is EDIC 2 because the course is Trics 2, what we are starting. And this is the introductory class. We thought to make you aware of the things that everybody is having in their mind, how to start with the preparation, what are the resource materials we should read, and how one should jump into the preparation battle and do it successfully. So we all know we want to come with flying colors very successfully with distinction, and that is EDIC 2. Now, the EDIC 2 is just like having the World Cup soccer in their hand, and everybody who starts preparation just 4 months, 5 months before, just today, if we are having 100 candidates, so everybody aspires to have the soccer in their hand. But when we start with, it's all with smiling faces, but when the results come, it is only few people who could get success at the end, and few, despite all of their big efforts, they cannot reach the target. And we are here to make you help in your preparation as well as pass this hurdle. Now, it's not easy. The preparation is definitely have to be strategically planned, and you have to start with all of your big efforts, and it's definitely worth it because this exam is having certain things which are right now after 2015. This is EDIC certificate entitles you to directly practice in UK, and many countries, European countries, they are also accepting this as the final exit exam for the intensive care medicine. So hope everybody is ready to start the journey with us. Now, there are certain well-proven points in critical care just to set the pace of today's presentation. We all know critical care medicine is no longer a subspecialty or a specialty. It's a super specialty now, and it is ever evolving. Whichever exam you are planning to appear, maybe it is European diploma, maybe it is our DRNB, maybe it is our DM exam. So it needs focus, strategy, and finally practice. The EDIC examinations are more comprehensive and they need proper planning to appear as well as pass. The preparation which you would start maybe with us or alone, that needs to be guided, and you have to start early for the success to be guaranteed. The problem with today's preparation without any structured course or in our busy schedule is that we do not have a structured course format, and we do it with unplanned and heterogeneous academics amidst your clinical curriculum as well as your busy practice. We deal with large number of patients in our hospital, So our duties, our working, the schedule, we do not get enough time to prepare, just like what we were doing in our MBBS days. The main problem today, we do not know what to read, and more specifically, if I will be like making it clear, we do not know what not to read. So sometimes we get indulged in so much of reading, and finally when the examination comes and the examiner asks us question, we think that we have lost or we have wasted our time in like going through the stuff which is actually not needed. Now we are more focusing on the clinical management in our respective hospitals, in our BG ICUs, and less focus on certain academics. Now there is no one in our hospital, in our medical college, or in our like the surrounding who anymore holds our hand to teach and makes you or like me or like us learn or like smarter professionally. So we are all colleagues, but definitely we need some like teachers who would be helping us to sail the difficult journey. We do not get enough time currently to study like our MBBS days or our MD days. And we are aging all that, we all accept that, we all know that, and we are also get busy with our family in our day-to-day stuff. So these are the things, these are the problems, despite which we plan to do some academics, we plan to clear many examination in critical care for our own satisfaction purpose. In our career we want to move up in the ladder, so definitely EDIC is one of that plan everybody is having. And today I think most of us who have joined this discussion, they are planning for this EDIC examination. Now we are here to help you as a team, and we are here to help you, we are here to advise you, we are here to support you, we are with lots of tips and tricks, and that's the reason why we made the title of our course also Tricks. And we are here to guide you and assist you with our experience over a couple of years, as well as the feedback from our previous trainees, successful aspirants. So some disclaimers before this presentation flows in to the like core of its the discussion part. This is not an official presentation from ESICM. The views what we are discussing today is based upon our experiences, as well as the experience what we gained during preparing for our own examination few years back, as well as teaching over years to many candidates for the EDIC as well as DRNB and DM. The candidate who are preparing for the exams, they are free to follow their own path, brain and heart. This is just some suggestions what we are planning to give, and we are here to guide you with many exam, typical the mock test, some domains, the practice test, questions, so that you will be ready for the final exam. And this is a systematic way that would help you all to clear EDIC 2. So what is an EDIC exam? I know most of you have cleared EDIC 1, but there are certain candidates who are planning to appear for EDIC 1, EDIC 2, and they have joined today's session. So for them, EDIC exams are conducted by the European Society of Intensive Care Medicine, that is the ESICM. It's a very reputed, prestigious association. The EDIC examinations are set out in two parts. Part 1 is the written exam, and part 2 is the clinical or oral exam. The exams are conducted normally twice every year as spring and autumn session. The EDIC, the diploma itself, that seeks to standardize the education as well as the training of quality intensive care, not only in Europe, but beyond. And believe me, EDIC exams are meticulously developed, and continuously they try to update it to create standard exit exams which accurately try to reflect certain assessment goals, and they try to address that the successful candidates should have the necessary skills, attitude, competencies, and knowledge that is required for practicing intensive care in any part of the world. EDIC acceptance, I have already told, it's a key component of ESICM's education strategy, and it's a standard of entry into intensive care specialist practice in Europe. In UK, it is regarded as ST3 or above. Many jurisdictions in the Europe, they specify EDIC as a professional qualification, and increasing numbers of like the students from India as well as the nearby countries that attest to its widening acceptance. Definitely, you have to check for the updated guidelines, the format from the SISM website itself. Now, how to start preparing for your EDIC exams? So if you are planning for EDIC 1 or EDIC 2, so you have to, preferably as per our advice, you have to open one account in esicm.org. You have to complete your EDIC profile, which is a prerequisite for you to register for the exam. And we recommend you to become the member of ESICM, and that is renewed annually. But definitely there are certain advantages of becoming a member of ESICM. You get some academic modules that is named as S. Previously, it was named as packed modules. So there are the academics modules prepared by the SISM teachers, and you would also get access to the events conducted by SISM, certain courses, their presentations also. You get discounts on the EDIC exam fee, as well as different ESISM conference, their annual lives conference, and ESISM preparatory course as well. And you need to go to the site mentioned in the slide to know more about benefits of becoming member. Now, if you are applying for EDIC 2 for the upcoming season on May end 2023, definitely you have to pull up your socks now. It's almost right now 4 months or so, and I hope, and many of my co-faculty would agree, definitely it's high time you should start preparing in a structured way, in a systematic way, and in a planned way. Otherwise, it's not good enough just to start preparing without any target in your mind, any goal in your mind. Now, the format for part 2 exam, just for the sake of people who are not knowing it properly, EDIC part 2 exams are different from part 1, being the oral or clinical based exam, and they follow the model of a objective structured clinical examination, that is OSCE, and the pattern is a blueprint derived from the competencies listed in the Covatrice syllabus. So Covatrice is like their own structured format, and they take all the domains from that Covatrice format itself. And you can visit that esism.org education Covatrice also to know details about that. For the exam guidelines and regulations, you can visit their own website to know the current guidelines and also the regulations. The format is like this. You have to go through 3 to 4 clinical case scenarios, that is CCS, and 3 computer-based stations, that is CBS. So popularly, this is CCS and CBS. So CCS is clinical case scenarios, CBS is computer-based stations. Computer-based stations includes biochemistry, images, curves, and graphs. So I would be describing one by one. You have to compulsorily pass the previously it was like individual CCS and CBS sections, but last time it was a combined mark. So if you have to like pass the CCS as a whole and CBS as a whole to like qualify for the EDIC. That means if out of 3 CCS, if like in 2 you are pass and 1 you are fail, but your total marks is actually more than they calculate normally based on the total the candidate's performance. So if it is more than the total candidate's performance, they normally set the mark, pass or qualifying mark. If it is more than that, despite the third CCS you are failed, but finally your result will be pass. So you have to pass CCS as a whole and CBS as a whole. Now coming to the CCS, these are actually the real cases managed in European ICU. So these are not fake cases or like some tailor-made cases, but yes, they take the cases directly from their own ICUs and they put in the real the EDIC 2 exam as a scenario. Now they are going with the online format for a couple of years. It started after this COVID and it's still continuing. So this time also in May session, they would be going with the online format. So before the exam starts, you will be given a vignette of a case around 25 to 30 minutes in advance. Again, that is variable. Last time also they provide you a clinical vignette 5 minutes before the real exam starts. And in the 5 minute time, you will be going with the first vignette of the CCS1. And after that, it would continuously flow. And they would be giving you or providing you the second clinical vignette, the third clinical vignette, then the fourth clinical vignette, depending upon the clinical case. And once the CCS is over, one, then they will go ahead with the CCS2. So there you will not get like any more time to read and get prepared for the CCS. So you have to go through the different like clinical vignettes, and the questions will be based upon the clinical vignettes on the case. So it would normally the time limit is around 20 to 25 minutes for one CCS. So if it is two CCS, it would be around 50 minutes. Sometimes they also give one or two short cases or short CCS. So again, it will be vary from like from examination to examination, but normally it is all CCS and CBS. So answers to the clinical vignettes carry 1 point each. So if a question coming from clinical vignette 1, I would give you examples, and in our the exam preparatory course also, all the discussions, the CCS and CBS would be asked for the real EDIC 2 exam. So it would be making you aware of like how to answer and what should be the correct answer proportion to get almost 70%, 80% marks. So the more you answer, the more marks you get. Previously, 3 to 4 years back, it was 5-pointer, 3-pointer, 1-pointer. But now they have removed this 5-pointer, 3-pointer, 1-pointer. Now the answers would carry each 1 mark. So if a question is like supposed to have 5 answers, so if you are answering 3 out of 5, so you will get 3 by 5. So if you are answering 5 out of 5, so it will be 5 by 5. That means 100% marks you are scoring. Sometimes the examiner has got the leverage of like giving you extra marks. Maybe that answer would not be in the suggested answer format or the answer sheet. But if you are answering it correctly and the examiner is convinced that yes, this can be also one answer, so they can instantly give the answer to you despite the answer is not in their answer sheet. So that is like one more thing what I want to highlight. That means if you think something that it is appropriate for the clinical case, definitely you should answer rather than only thinking that if I would not be like telling from the answer sheet, maybe the examiner will not award me a mark. Usually, if there are 3 CCS, one would be normally surgical, the other one would be medical, and the third one would be a subspecialty specific. That means in neuro, cardiac, onco, transplant, something like that. Now coming to the CCS. So it is normally 25 to 30 minutes time you will get for one CCS, complete CCS. So you have to start preparing before the case starts, the discussion starts. So think about the questions they might ask you. That means you have to dissect the question, the clinical vignette 1. So some common questions normally the examiner wants you to answer when they would be asking, like summarize the case. So this would be a favorite question from the examiner, and you have to answer in like 4 to 5 answer for each questions that are worth points, and you have to be brief and to the point. Then they normally also are keen to hear about certain organ dysfunctions that we normally face in our day-to-day ICU practice. And history will almost always not important to mention for these questions. Like they would be asking you, what is your differential at this point of time? What is your immediate management for this case? What are the further investigations would you want, or like right now you are asking from the lab? What can be the cause of this patient's certain complications that this patient witnesses, like agitation, suddenly the patient is having fever, suddenly the patient having shock, suddenly this patient having decreased urine output. So that can be the questions by the examiners. Now, maybe in the clinical vignette 2, clinical vignette 3, the case would evolve as it normally happens in our ICU after 2 days, 3 days. And you should not be surprised, or I would say you that you would almost 80% time you would get a case of cardiothoracic that would be ultimately evolving into a neurosurgical. That means the INR will be high suddenly and the patient will be having intracranial bleed. Patient is now shifted to the OR, neuro OR, and neuro monitoring has been started. Patient is not improving, and then you will be planning for like brain death, something like that declaration. So cardiothoracic is turning to a neurosurgical, and at the end it would be communication, counseling, and so on and so forth. So in the discussion part from the cardiothoracic ICU, they would be giving you something related to the cardiothoracic investigations like ECG, IABP, something like that. When the patient is shifted to the neuro OR and after that again shifted to the neuro ICU, they would be providing with the CT brain, they would be providing with ICP waveforms and different other neurosurgical or intensive care interventions. So you would be given a plethora of investigations that you have to correlate just like we normally witness in our ICU. So it would be very clear. You have to make your reflexes sharp and you have to think like you are one of the attending in the ICU and you are taking care of the that patient, taking most of the decisions. Further, certain questions that you would expect from the examiner, they can ask you something related to the physiology. They can ask you something related to the current evidence related to that case. Do not be alarmed that you have to go with the detail of the like evidence. No, you have to mention about some actual trial names and how you do it, how the trial is actually right now pertinent to the current clinical practice, and that would be more than enough. There may be certain questions regarding counseling the relatives, definitely. And for that reason, we have one lecture today by Dr. Swarna Deepak. He will be explaining you about the communication part, the counseling part, the certain like questions related to ethics. That is very important in European exam, not only for European, in Indian exam also. This is very important so that you will be definitely getting some clues. And they may ask you, they will like keep one or two complications that happen during the ICU stay and how you are going to handle if certain error has occurred. So that is also one of the favorite questions normally they put. There may be questions on end of life care, brain death determination, and organ donation. So very important things that I hope everybody should be clear in certain aspects of the critical care. Now coming to the CBS, there are 3 stations. I have already like reiterated that CBS 1 would cover ECG and other curves and graphs. CBS 2 would cover radiology, ultrasound, focus finding, something like that. CBS 3 would be covering ABG, biochemistry, data interpretation. So this is the normal division of CBS. And you have approximately 10 to 12 minutes for 8 to 12 cases. That means each question 1 minute, around that. So these are the stations, or these are the like the questions that probably is the most difficult ones from previously, like whoever like our trainees, they have appeared, the feedback from them, as well as what we have also witnessed in our own practice, as well as when we have appeared the exam. CBS is comparatively difficult because it is like having short time, and you would be getting like one question from neurology immediately, the second question would be from cardiology, third question would be from nutrition, fourth question would be from hemodynamics. So you would definitely be jumbled up with so many questions, and it is tricky to prepare for them and answer in the limited time. Now, all the cases in the CBS also, they will come with a brief clinical information, that is clinical vignette. And many times what we experience and what we get from like feedback from our students or trainees, that the clue is in the question itself rather than on the image itself. So read the clinical vignette first, go through that image, and usually there are questions regarding management also. So there would be one question, what is the waveform, and then how you will like troubleshoot that. So these would be the questions. Normally 2 questions would be there, and the suggested answer would be around 4 answers for question 1, 4 to 5 answers for question 2. Again, I have already told you barely have more than a minute or so for each case. Now coming to each CBS, I would be little bit elaborating for the candidates. Curves and graphs, it can be any curves and graphs from the critical care, like variety of ECG. ECG, they can deal with myocardial infarction, heart blocks, drug toxicity, electrolyte disorders, pacemakers, arrhythmias, and their management. So we normally suggest that you can divide the ECG into these type of domains, start collecting the ECGs and put it in the the folder and revise it and prepare it much time, like almost like 5-7 times before the real exam. Because one time you may forget the important classification of different ECGs and their management. Ventilator graphics, auto peep, trigger, cycling, asynchronizing, peak plateau pressure, like it can be anything, but yes, these are the most preferred questions in the ventilator graphics. CBB curves, yes, the complications normally they ask tamponade, regurgitation, stenosis. IABP, it can be like the troubleshooting. Normally the examiner is very fond of asking early inflation, early deflation, late deflation, something like that. ICP, there are many waves related to ICP. You have to be really confident about answering, and that can be asked in your ICP waveform table. Simple CRRT pressure trends also. Now it is like a very common question. Troubleshoot the pressure changes, and also ECMO. ECMO is one of the most preferred the question bank. Normally the European examiners normally they ask, and you have to troubleshoot for the pressure changes and the oxygenation part. The biggest problem is like there is not a lot of resource online for the CBP, ICP curves, but you have to collect it from different sources and try to revise it multiple times, not only at home, when you are at the hospital also, in your ICU also, try to practice at work. That would help you in the real scenario when the examiner is asking you something. Try to sometimes take help from your colleagues in understanding the different waves. Coming to the radiology and image part, the list normally they say are emergencies which we should be able to recognize before the official radiological opinion. That means this coming to the CT head part, it can be traumatic brain injury, EDS, SDS, SH, diffuse axonal injury, ischemic stroke, bleed, hydrocephalus, CT angio pictures, CT abdomen, it can be again intestinal obstruction, pancreatitis, pyelonephritis, free fluid under the diaphragm, solid organ trauma, aneurysmal bleed. CT chest, it can range from contusion, infiltrate, collapse, aspiration, aneurysm, hematoma, empyema, refracture, pneumothorax, pneumomediastinum, different lines and tubes in the CT chest. Chest X-ray, that gets quite extensive. I know everybody knows what are the normal chest X-rays. The examiner is very fond of asking. IVP tip, they can also ask. They can also ask lead fracture in like your normal pacemaker. Abdominal X-ray, that can range from ileus, hollow viscous perforation, small or large bowel obstruction. IBC filter placement, that is also a favorite question. In the ultrasound table, they may be asking you different signs related to pleural effusion, consolidation, pneumothorax, hydronephrosis in the abdomen. In the echo, focus, IBC, reduced systolic function, then tachycardiomyopathy, cardiac tamponade, pulmonary embolism. These are some of the favorite questions from the examiners. So it's a wide range of topics to be covered. I know it's like easy to tell, but definitely very difficult to like prepare, and you have to go with many resources in the website like radiopedia.org. You will find plenty of images, and you can practice it at your workplace, as well as you can discuss with your radiologist friend to clear your concept. Now coming to the radiology image, I have already told this. Then how to prepare for the part 2? Almost the format is same as part 1, except it is like a clinical exam and a bedside exam. But now as it is online, so definitely you have to be like make the examiner convinced that you are good at like at the bedside clinical examination and deriving some conclusions at the end. You need to start preparing at least 6 months prior to exam, but minimum 3 to 4 months are enough if you practice it in a systematic way. Basic knowledge of critical care, I hope everybody is having that. You have already gone through the standard critical care textbooks. It is mentioned in my later slides, but yes, they want to test your knowledge and ability to become or award you as a consultant who can take independent decisions on the management of critically ill patients in your respective ICUs. Now, how to prepare for part 2? We all know that the critical care training is based upon how you start assessing or investigating or clinical examining. As soon as a serious patient or sick patient is trolleyed into the casualty and you start looking for the ABC management, followed by certain investigations, certain procedures to stabilize, then certain medications you would prescribe to treat. So be attentive in the wards, in the ICUs, observe everything that is like done to stabilize a sick patient and keep discussing with your colleagues. That is one of the major thing what we want to highlight, because it's all about how you vocalize and how you like connect the dots in front of the examiner who is at the other side, not also in front of like you in the same table. So you have to make them convinced that yes, I am confident about our management. I am confident about deriving some conclusions and do something which would save my patient. So this is sort of a practice for the exams, especially for the clinical case scenarios. And for the CCS also, you have to look into everything that is available in your ICU or what you normally advise. The take, rotem, the like different equipments like HME filters, capnograph, pacemakers, ECMO, CT, MRI, everything they can ask you. You can go through the S modules from ESICM, but yes, because of the time constraint, definitely it is very vast. So maybe if you are thorough in your text, maybe you can go, but yes, that depends upon your own clinical judgment. There are self-assessments after completing each S modules, which are quite helpful. So how to prepare for part 2? We normally advise that you have to always be updated with the ESISM websites about their upcoming informations, the scientific events. Sometimes they take the questions or cases from that webinar or that like the course they normally conduct and make it available on the website. You have to be updated with all the like recent trials, the landmark trials, and the final conclusion, because sometimes the questions would be based upon like the evidence normally like we are getting from the recent landmark trial, and you must be thorough about all the recent advances that is happening in current clinical practice. You should prepare certain notes, handwritten or on iPads, tabs during your exam preparation, which should help you during your last minute revision when you will be doing just 15 days before your real exam in the month of May. There are certain textbooks I would advise, or most of our faculties would normally like advise. Maybe it's a European exam. So OS Intensive Care Manual is a preferred book. Now, this is the most recent like critical care book by John Louis Vincent and Bellomo as well as Marini. This is the 8th edition textbook of critical care. But yes, if you have not read it before, never jump into that book. Irwin Rippe is a one of the most preferred textbook, but yes, it needs time. So 3 months, 4 months before, I don't think you should start with this type of books. Rather, OS manual is a standard textbook which you can go through or refer in case you have some difficulty in your like concept clearing. These are other textbooks. I'm not going into detail of this. There are certain internet resources that will be very useful because the time is the key now. So Life in the First Lane, MCRIT project, deranged physiology, up to date, ICU one pager. So these are certain few like you will say the internet critical care resources This is like the foam material that would be really helpful. There are certain books like examination, intensive care medicine, data interpretation in critical care medicine, which are helpful for your CBS preparation. OSCEs for intensive care medicine, OSCEs for final FFICM, ECG books, the cases in the chemical diagnostic approach, the objective structured clinical examination by Jonathan and Daniel Wentz. So finally, I'm not going to teach you everything that is required because it needs time. And definitely my colleague is waiting for her, like his lecture to be started. This is the format till now. What we have done, we have conducted one introductory class on 7th of January. Today is the second introductory class. We are starting our Trics 2 course on 10th. The first exam is cardiology and cardiac surgery. And the debriefing would be on 11th of February, where Dr. K.R. Ramanathan, who is a very reputed cardiothoracic intensivist from Singapore, who will be the mentor, and myself, and along with me, Dr. Sananta Kumar Das from Australia would be the faculties for the first debriefing. So with that, I hope in the month of May, we would be getting this type of certificates, diplomas in your respective hands, and you would be all be successful in your this noble endeavor. Thank you all of you for your patient listening. Any further questions, I would be happy to answer that. Thank you. So Dr. Swarna Deepak, if you can start your presentation.
Yeah, thank you, Tapas. Just waiting to see if anyone are going to ask some questions.
Yeah.
Happy to see my other friends like Manjunath also. Prasanna, I think I can see that some of the people were in the previous courses as well, right?
Yes, sir.
Yeah, good to see you all. So before I jump to the slides, the way this flow would be, it would be a short debriefing for you, not an extensive coaching on ethics and end of life and this kind of stuff. Just to review some of the principles and the basic flow of how to like go ahead with the end of life care. What are the principles about it? In the end, we'll be taking a couple of case scenarios just to see how the answers are expected from the examiners. Okay. In the end, I think I would tell you this end of life care and communications are a very abstract topic. It's not like you're very high scoring like point to point topics. No, for example, you have an X-ray, there will be finding, there's an ECG, there will be a finding. It's not like that, but you need to understand the concepts. And if you understand the concept, definitely, I think if you, as long as you're clear in the concepts, no, and more importantly, you should be clear in the concepts of Europeans. Not only for your Indian concepts. So if you do that, I think you'd be scoring reasonable marks. So to introduce myself, I'm a senior consultant in critical care and as well as an associate professor in general medicine. I work from Hyderabad. So just make sure that you all are able to see the slides, right? So it's like surfing this one. Imagine you are the person who is doing this and you need to go between these waves and have a good exam. And ethics and end of life care are one of the high scoring points as well. If you know your basic concepts, no, the questions are not going to be too complicated as long as you know the guidelines. You all know this like person, Aruna Shanbag, nurse from Mumbai. And I think none of us can actually like understand more than the medical persons the importance of having a dignified death. It could be a peaceful event or it could be a event with great agony, especially when you actually don't have a proper protocol and you inappropriately sustain the life support, which in fact happened in this case. And she had a prolonged suffering as well. So brief references, you can have references. The latest one is from 2020 from like Indian Journal of Medical Research. Prominent authors like Shiv Kumar Iyer sir and R.K. Mani, they all were involved in it. And you have our own ISCCM guidelines as well. And from Europe, you have the guidelines. From Canada, you have World Federation of Intensivist guidelines. A lot of guidelines are there, but try to go through the basic guidelines which were given in your PACT module. Which would be helpful for you. So what is end of life care, and how will you initiate end of life care? End of life care is basically a multidisciplinary team approach, which basically will initiate in an advanced, progressive, incurable, and life limiting illnesses, where you try to give the relief for the physical, psychological, social, and spiritual symptoms as well, instead of only being objectively treating the numbers. And it involves the choice of the place where the patient wants to die peacefully, choice of the treating personnel as well, and it involves a lot of other terms which we'll be discussing, like withdrawal of life support, kind of other terms like DNAR. These are all, there are some of the topics which are different between the European countries and our country as well. So we'll be briefly touching them. So this is a basic approach in initiating the end of life care. You need to first identify in which patients you need to initiate and when to initiate. Before you do that, and before you go and initiate it, you need to assess the physical and non-physical symptoms as well. Here, if you have an availability of a prescribed format like your NIH guidelines or JCA accredited guidelines, no, where you have an end of life care form and end of life care nurse as well, try to make use of it. You need to plan the site of care, review the medication chart, and stop all the unnecessary interventions, medications, and investigations once you establish this EOL process. And you will be providing the essential medications, will be coming to that. And once you start it, your goal doesn't stop there, and you'll be reassessing the regularly, like pain control, other nausea. And ultimately, once you start it and once you complete this process, you'll be going back and reflecting if there were any gaps. So this is a basic six-step approach. Going forward, once you diagnose any disease, this is the flow of the sheet in given IJ, Indian Journal of Critical Care as well. So you can see this yellow graph and the blue one, both of them will be simultaneously given. So your curative intent and palliative care intent, no, both of them should be together. One is not absolute. Okay. So once you diagnose a disease, depends on the disease and depends on the prognosis, you'll be starting the curative process as well as simultaneously giving the palliative care as well. And the amount of proportion of each of them will be varying based on the disease course and the prognosis. And once you're very clear that there is no clear disease directed treatment, your end of life care is the one which will be going into. And your job doesn't stop there. And even after the death, the bereavement process also you'll be supporting it. So these are the basic bedside checklist. The basic things you need to check is whether this disease is in the advanced stage, whether there is a really poor prognosis and there is no real-time prognosis for the patient as well. And you need to make sure that these all absolute entities are filled up. There should not be any doubt in establishing these checklists. And ultimately at the last point,
Kavya, he's not free on.
Manju, I think you're talking. Patient and family preference to limit and life support or refusal to life support is the one which I would like to point out. You need to always involve the patient and family preference, especially because most of our ICU patients are having a doubtful competency in taking the decision of these major decisions. So the priority patients are severe irreversible brain damage, irreversible multi-organ failure, metastatic cancer, which is not responsive to chemo, radio, and patients with decision-making capacity who decline intensive care and who wish to receive comfort care. So this is the called as principle of autonomy, which we'll be discussing later in the slides. And brain death and who are not organ donors, and patients in persistent vegetative states, patients who are permanently unconscious. So these are called as priority patients in whom end of life care should be initiated. So coming to the Indian perspective, what are the barriers? I will be briefly touching this. So the barriers can be from the patient side, barriers can be from the clinician side, or barriers can be from the family and as well as the system perspective itself. Predominantly from our side, your barriers are your ability to not to recognize the priority patients which are shown in the previous slides, and lack of education or proper training in actually being comfortable in initiating and maintaining the end of life care. And there's a fear of law among the doctors. We'll be coming to the next slide where there it is not substantiated. And communication skills are extremely vital for all our intensivists, and especially in this kind of sensitive settings. No, so it is much more important. We need to develop. We'll be seeing them as well. And fear of death in the lay persons and doctors, both of them, see, there is nothing to be afraid of the death. I think if you have seen a movie, no, Patch Adams, which I would always recommend at the end of this session, go and see it. And it is not like a birth. I think death should be the dignified one as well. So this is a picture which is depicting clinicians' barriers, patient barriers, and the family barriers. Whenever you are trying to initiate an end-of-life care, you are doing a noble job and you try to systematically address each of them. So as you can see, there may, from the family side, they may have unrealistic expectations. They may be thinking that there may be lack of coordination between the treating team and the family as well. So you need to address it. And before you address it, always make sure that you're talking to the person who is actually in an hierarchy. There is something called as a hierarchy. So in the decision making power, you are talking to the person who is actually in the proper setting. Otherwise, there may be a confusion of talking to a wrong person, and again the entire decision will change once the right person comes. And physician factors we have seen, and physician doesn't mean that you are alone, and your treating team, like your registrar, your nurse, your palliative care nurse, your priest, or all this team includes the same single team, and you should always be on the same page. And you should have a congenial environment to have initiate this compassionate end-of-life care. How to overcome these barriers? If you could actually establish a fixed policy, at your institute, that would be really helpful for you. At our institute, it's a JC accredited policy. We have an end-of-life care policy. We have an end-of-life care nurse, and there are dedicated places like some rooms where there will be less noise. There will be access to the anesthetist, pain control. So all these things needs to be designated in your place, and there should be a proper protocol in place. Otherwise, what will happen once there's a deterioration of the patient, there may be a medical person who is not actually aware of this, and they'll be shifting this to the ICU and becomes a mess of it. And you should be always available of the patient's right. We'll be coming to the principles of ethics and patient's rights. And always remember, communication is the key goal, and which will create an impression on the patient's family. The patient, we know that they may not have a reasonable prognosis and they ultimately die. But if you have a reasonable protocol, I think they'll be left very much satisfied. So coming to the most important thing, we'll be slowly overlapping with the communication part as well here. So your the 4 goals are: one is an autonomy, beneficence, justice, and non-maleficence. So these are your obligations towards for the patients. Whereas the patient rights are, he can always refuse the treatment at any point of time. He can always stop it. And patient has the right to execute a medical decision maker, especially when he anticipates that there's a loss of decision making. For example, he might be undergoing a neurosurgery. He might be on a ventilator, and he might be on a sedation, or maybe he knows that his dementia is progressing. He can have a capacity to actually keep someone who can take the decision in his place. And so if he can take the decision, it becomes easier for you. But most of the times it will be a very rapid one, and our system is so immature that you don't have an actual decision maker. There comes the hierarchy for the decision making capacity. So we'll be looking in the case scenarios. And appropriate withdrawal or withholding of life support. Always remember, if you follow the guidelines, it will not attract a criminal liability. So coming to the principles of ethics, and there are 4 principles. The most important principles is beneficence. So in simple terms, it basically indicates that you are doing whatever the measure you're doing, it should be in the best interest of the patient with a curative intent. And best interest, if at all, if the disease is not getting better, you will be stopping it in the best interest of the patient, because we are prolonging the process of actually suffering rather than the improvement. So this concept is beneficence. So you will be seeing 4 principles of ethics, and remember that at each case scenario, you'll be asked which principle of ethics are you going to apply. So what is non-maleficence? Maleficence is doing harm, whereas non-maleficence is you don't have any intention of doing harm. So whenever you are faced with a kind of decision at the why, where you have two varied options, you need to take a decision which basically you don't have any thinking of doing some harm for the patient. And especially continuing the life support in a dying patient, it basically prolongs the agony. So it is considered to be against this principle, and it adds to the economic and emotional burden on the family. Most important principle, and the principle which Westerners are fond of, is autonomy, where we are not that comfortable in an Indian setting where we have a paternalistic approach. So you should always respect the patient choices and preferences. And if the patient has lost the capacity, the preferences must be elicited from the next of the kin. See, there may be complex scenarios where there may be a live-in girlfriend, or maybe there may be a spouse, there may be a parents, there may be first son who will be quarreling with the second son. There are varied hierarchies. Go through the reference book, and I would suggest you to read through the MRCP books here. I'll be sharing with the group later on. So there's a specific autonomy and hierarchy. So you should follow that. And you should always be open and honest, and you'll be disclosing the complete information instead of giving the partial information. And remember, proper treatment, taking an informed consent and documentation is absolutely mandatory. And coming to the last principle of social justice, we have seen in COVID where we are short of resources, and it's just an example of it, especially when you need to allocate valuable resources, and you'll be offering to the person who deserves the justice. And here there should not be any discrimination between 2 or 3 patients, and all of them should be treated equally. This is called as principle of offering the social justice. And all your communication scenarios will be revolving around these 4 principles, and you need to be very clear in the definitions and the principles of these 4 principles of ethics. And the infrastructure, we already discussed. You need to have a specific policy, spacing, and staff in your hospital to establish this. And you can, if you don't have it, you can make use of your ICCM guidelines and national guidelines, ICMR guidelines, in having these policies. I think this is self-explanatory. So coming to the other most important, verbal communication and you have verbal communication and you have non-verbal communication, both of them. Whenever you're facing a difficult situation like end-of-life care, difficult patients, difficult team members, right? Or maybe there may be a medical terror. See, in communication scenarios, there are almost 24 scenarios or 30 scenarios given in the MRCP books. So right from going to the breaking the bad news protocol, which is very important and expected in almost every exam. There are other scenarios like difficult patients who will be quarreling with you, who will be arguing with you. There may be a surrogate who will be mimicking that, or there may be a non-cooperative team member. There may be a medical error. How do you manage that medical error? There may be a setting where there will be a medical negligence as well. So you need to, there are a lot of scenarios. You need to train each of the scenario, need to practice them. So for all these things, the communications skills are extremely vital. Among them, non-verbal communications. Non-verbal communications is where there won't be much talkative part. So it almost will be contributing to 80% of the proper communication. Communication is not a one-way thing. It is not a thing which you will be talking and the patient will be listening. So you need to listen to the patient, and almost most of the studies, they show that listening part plays a huge role there rather than the talking part. So you need to have a protocol. So the art of having the non-verbal communication, you need to sit square, face square, and you should have an open approach. So it doesn't mean that it should not cross the arms and legs. You should lean forward towards the patient, make a direct eye contact with the patient, and you should have a relaxed approach rather than seeing your phone, answering your phones or messages. So this is a specific, you have other protocols like value protocol. There are other protocols given in various books as well. Try to establish one protocol. The second protocol you need to train yourself is breaking bad news protocol, the spikes protocol. So you can have a scenario. See, I am very sure that one of your exam, you'll definitely have this protocol and the scenario on this. So spikes protocol basically is you need to have a setting up of the interview. You need to have a specific room for it, noiseless room with a glass of water, maybe some of the tissue papers. And you need to assess the patient's perception before you actually break down the bad news. You need to ask the patient to contribute what he knows about it. This protocol is more designed for the oncological patients where they're being given the bad news. Rather than here, you can apply for the patient's families whose attendant, whose family member is very sick in the ICU. So you need to invite from the family as well, what do they know about the patient, and you should give the knowledge to the patient later on after knowing what the patient knows, and you should give it in the multiples of small aliquots. Okay, so you should not dump the information and knowledge directly to the patient. And once you do it, you should assess the patient or patient's family's emotions. Okay, there is something called as empathetic response. Okay, there's a specific algorithm for it. For each appropriate emotion, for example, he is angry, how do you react to it? You'll just show a silence, maybe nod with them. Okay, or if the suddenly crushes with the kind of crying or something, what do you want to do? You need to learn these specific targeted empathetic responses. Ultimately, once you address this till step 5, you'll be planning the strategy and summary of the patient. Okay, so this is called as spikes protocol. And coming back to our patient who you're starting, this is the basic protocol which we will follow and given by our society as well. Once you clearly, objectively and subjectively assess the patient's futility, the dying process, learn about the concept of futility as well, the medical futility. And you should actually have a consensus among all your caregivers with all the multidisciplinary teams involved. And then you'll be honestly and accurately disclose the prognosis to the family. Here, the third step, you'll be following the spikes protocol. After disclosing this one, then we'll be discussing the 6th step where you'll be communicating what are the strategies you have, what summary of the overall treatment modalities available. Then once you do that, you'll just take a break and listen to what they feel, or maybe give some time to them, come back to them, and then there will be a shared decision making. So there is shared decision making. One is an team sharing decision making, and other thing is with the shared decision making with the family. So there are both of the two protocols are there. Once you do that, then you document all this procedure, and then you'll be having a consistency among all the team members. So there should not be any doubt once you start this end of life care. And they'll be compassionately applying the end of life care. And each point of time, remember, the patient has the autonomy. The patient's family has the autonomy to withdraw entire procedure and go back to the full treatment. So what is the legal position regarding the end of life care in India? ISCCM has always advocated for the ethical and transparent decision making, and ISCCM recognizes do not resuscitate orders, both the withholding of life support and withdrawal life support as ethical interventions. But remember that the terms euthanasia and physician assisted suicides are different, like which are sometimes approved in some European countries, but at least on an Indian perspective, they're not approved. And in Aruna Shanbag case, the Supreme Court ruled that the passive euthanasia was permissible, but this passive euthanasia term itself is a bit of controversial thing. Okay, but it's a so lengthy procedure where you need to apply for the magistrate approval. You need to again see that they'll come and assess the patient. Again, there will be an independent team. There will be, so it's a lengthy procedure in India still. We hope that it will shorten up and do it. And the problem with having the short protocols in India is there are too many family members involved, and the medical care itself is not clearly systematized. So it's still in the gray zone. But at least remember, we have still some legal background with us and some backup with us. So you can see this commission report in 2006. And it basically legalizes that withdrawal of life support where it is appropriate, and it provides the protection for doctors where they are performing appropriate end of life care and should not be afraid when it is medically futile. And it acknowledges our ICCM role as well, but it does not recognize the patient autonomy or living will. Again, it going into a gray zone here. Whereas the next one in 2012, passive euthanasia, which is allowed in many countries, but it has so many safeguards here. So it is not objectionable from legal and constitutional point, but at least from my knowledge, the euthanasia part is still term which is not still accepted. In 2008, subsequently, there was a writ petition, and it's a lengthy judgment. Ultimately, the Article 21, it covers within its ambit only passive euthanasia, not active euthanasia, where the physician will be giving something, will be contributing to the physician-assisted suicide. So these are the terms you need to be really very careful in understanding the terms, and you need to know the definition as well. So you can freely see these terms in the position statement of the Indian Council of Medical Research. Will not be going into them. So physician-assisted suicide is different from our end-of-life care. Always remember and understand it clear. It is an intentional act by the physician on voluntary request of a dying patient with a terminal illness, where you will be providing means or methods which will helping a person to end his life, which is completely different, okay, which is not legal in India. Whereas palliative care, as you have seen in the first diagram, is the one with the blue graph there, where it is a holistic approach to the treatment. It improves your quality of life care of the patients, and they'll be having a peaceful passing away rather than very difficult, painful death. Okay, end of life care is an approach that shifts the focus from the page where you have seen once that pink graphs was started. No, it's where you are very clear there's no more of a therapeutic options are left. Advance directive, a statement made by a person with decision making capacity, stating his or her wishes regarding how to be treated or not treated. So remember, this advance directive needs to be clearly documented on a legal document with a magistrate signature and approval. Then only it will become a approved advance directive. What is the current state of DNR? Anyone has an idea? So this is the algorithm for do not attempt our decision making, DNR decision making in our India. So this is from the latest document in 2020. What does that say? You need to, in this one, the most important thing is the patient medically futile or not? Okay. For example, what we're talking is if there's a medical futility and you'll be discussing the patient who will be having a cardiac arrest, the most important thing is determining the competency of the patient in giving these orders. Okay. If the patient is incompetent, if you're not really sure, there is no need to discuss DNR at all. Okay. If the patient is competent and he was clearly informed about the prognosis of the overall pathway, is medical futility, and there may be a clear magistrate documented advanced medical directive, then you can clearly approve the do not attempt to resuscitation, where you have a legal document and legal backup as well. Where here, if you are not sure about these things and there is not of a clear documentation of the patient's competency or advanced medical directive, maybe you need to take, if you still think that there's a medical futility of this patient, no, then you can take the opinion of your legal team in the hospital, then you can go ahead and initiate it. But here it's a gray zone where most of us will not go into it. So coming to this, at least till this one, the takeaways are you should always initiate discussions and both the harms and pros and cons of the disease, and as well as doing the CPR, and all the DNR should be documented very clearly and should be signed by the entire treating team. And before you do that, there should always be clear documentation of explanation for all the curative options as well. DNR doesn't mean that withdrawal or withholding of the other life support treatments. DNR is different from the withholding and withdrawal of the life support. And all the forms should be signed, stamped, timed, and dated by the surrogates of the patients or patient as well and the treating team. Okay. If they do not sign it, then try to again go back and discuss with them or try to withhold it. Since CPR is a form of treatment by the treating physician, final decision lies with the treating physician. So if you think that it is medically futile and you're not doing a social justice and it is not with the principles of your beneficence or non-beneficence, you can always take your independent decision as well. We'll be coming to that. In case of conflict of multiple decision makers, you need to sit with them, you need to discuss with them and come to a single opinion rather than jumping to a conclusion. Okay, so So if you're going to the 3 or 4 case scenarios, these are the basic competencies the EDIC people expect from you. You're expected to manage the end of life care and process of withdrawing and withholding treatment with the multidisciplinary team. So here they'll be given case scenarios, various complex case scenarios, and they'll be asking the best options in the next step. And you're expected to discuss the end of life care with the patients and family surrogate in a compassionate way. Okay. Yeah, understand your life was simple with your objective exams and ASCIIs and in the online exams. But if at all, if this scenario comes, you need to train yourself. And you're expected to manage the palliative care of the critically ill patient. Okay, palliative care doesn't mean that the patient should always have a malignancy. All the critically ill patients with an advanced course and poor prognosis comes into this. And you're expected to involve the families as well. And you're expected to know the the decision-making hierarchy of the families. Okay, you are expected to know that. You're expected to know the culture and religious beliefs and respect given to them. And ultimately, you're expected to know all the 4 principles of ethics and the communication. So, one of the scenario, the importance of informed consent. 4-year girl was asked to donate the bone marrow. You must have seen this one on one of your TikTok videos as well, right? To save the life of her baby sister. After harvesting the procedure, she asked the doctor when she was going to die, right? So this young girl, she's under the presumption that giving the bone marrow basically means that she's giving her life and donating her life to the baby sister. She's going to die. So once you see the problem here is there is no informed consent. There was no clear explanation to the girl that it is not a procedure where life will be taken away. It's a donation. So it can apply to the other scenarios as well. So this is an informed consent and the importance of this procedure. So a couple of scenarios, you can type your answers in the chat box. Right, 30-year-old male, head injury, withdrawing from the pain stimulus, pupillary response are equal, and brain CT shows bilateral frontal contusions and subarachnoid hemorrhage. The BP is around 160 and 0.6 FiO2 with SpO2 93%, febrile, and sugars are 70. It's been nursed with head elevated at 45 degrees. So this is your case scenario. So what are the principles you apply here? So the ICU doctor in this question, in this scenario, no, the ICU doctor has decided that patient requires a central line. Okay, for whatever it's worth, maybe you need to give a hypertonic saline, maybe you need to give a sedation, whatever it is, he has approached for the informed consent of the wife. So as we know, he has explained both the complications and pros and cons of the procedure and the wife wanted to know if she can avoid the invasive procedure and about alternatives. So you'll be asked the question, what ethical principles are going to be applied in this setting? We're giving 1 second. So what are the ethical principles you'll be applying for the in this scenario? If it is your exam question, anyone? See, your option to give into the chat box is the way you will interact with the examiner. Okay. You need to be proactive whenever these sessions are going in. I'll be going to the question. So here you're applying 2 principles of communication and the ethics. So one principle is autonomy, where you are giving the autonomy power to the family, the wife basically, to take the decision of whether to give or refuse the consent for the procedure. Okay. And non-maleficence is where you're trying to keep a central, you know that there's a possibility of pneumothorax bleeding and all, but your intention was not to do any harm for the patient and do something good for the patient. So these 2 principles are the answer for this question. Okay. So what are the 4 principles of ethics? Again, self-explanatory, autonomy, beneficence, non-maleficence, and the distributive justice. Patient's ICP, this same patient's ICP continues to rise, and the neurosurgeon wanted to go ahead with the emergency hemicraniotomy. According to them, it has a best result with good survival. It performed early, right? But the patient's wife doesn't agree with the surgery, saying that the patient expressed before that he doesn't like to undergo surgeries which prolong suffering. So what do you do in this setting? What are your principles here? What principles of ethics will you apply here before you take the decision?
Beneficence.
Okay, someone has told beneficence. Anyone else? So here you can see you asked the patient's wife and you are giving independence for her to whether to refuse or give consent for it. What principle is it? Exactly. So it's a principle of autonomy. Then what are you trying to do? The treating hand team has something at the best intentions at their heart, right? To if you do it to get him out, you know that it's a major procedure. Still, they have the best intentions at their head. What principle is it? What principle is it? So these are the options given in your exam. Which will be the exam? Which will be the option you will be selecting? Will you be exploring the patient wishes with regard to medical care with his wife and actually abandon the hemicraniectomy, or will we be the proceeding the procedure without the consent because it is still likely life-saving and any delay may outcome difference, or will you be involving the hospital ethics committee, or will you be calling other members of the family and seek their consent? What is your best option? Yeah, someone has told you'll be applying the principle of beneficence. Someone has told, Kavita, I think you told you will be applying the principle of beneficence, but again, you'll be going with the patient's wife. So both are on the opposite side. No? So there are A, B, C, three of the options are told by each of them. So the option is among all the four principles. See, here you know hemicraniectomy, right? It is not like if some procedure which has a very clearance. Yeah, agreed. Some of the treating teams still go ahead with it. Some of even, in fact, who also will be doing it. But provided that in this setting, no, you have if you have other options like raised for the raised ICP like medical options, you can explore it. Here, the among the four principle, which is the most important principle? The most important principle is principle of autonomy. So when here in this setting where our wife is the clear decision maker and there's a clear documentation from the patient that the wife would be the decision maker and he is not actually comfortable with the surgical procedures. So we're going to respect the principle of autonomy and going with the patient's wife's wishes. Okay, because you still have a medical care option. Your decision may change. For example, it's a trauma patient. He's bleeding like hell and he's losing and going into hemorrhagic shock. The setting may change and you may apply a principle of beneficence or non-maleficence. You may go ahead with the procedure. Remember that depends on the setting and the emergency of the procedure. Your application of the principle will change. So try to understand the subtlety. So this patient ultimately during the next 30 days of his course, he continued to deteriorate multiple invasive procedures, organ supports, neurological status also continued to deteriorate. And the neurologist is very clear that there's a permanent damage to the brain. Here, there's a lot of other family involved and slowly the family's views also changed. Now the treating team is not comfortable with continuing, but the family wants to continue all aggressive measures, right? Where the treating team is very clear that it is medically futile to continue any further. So what is the next line of action here in case if the patient deteriorates? So again, you need to go back to the 0 and apply 4 principles of ethics. So which principles will be applying here? Which law you will be applying? Okay. So here this law of medical futility or the concept of medical futility is very important. See, this scenario is different from the previous scenario. Previous scenario is an emergency setting where the patient is fit. He has just had an onset of the disease. No, that's a different scenario. Whereas the scenario here is very clear. He has a prolonged course and the team is extremely clear that it is futile. So if the law states and all the ethical principles states that if the treating team is very clear that it is medically futile, you can actually go against the family, document, and try to actually not aggressively prolong the suffering of the patient. Yeah, exactly. Yes, I think that Kavita stated it is non-maleficence also. You're doing something without any intention of doing any harm for the patient, and you're doing something to try to prevent the prolonging of suffering of the patient. You understand this concept very clearly, okay? Concept of medical futility. Lengthy scenario, okay? If you read it, I have given just in the options as well so that you'll understand both of it. elderly male out of hospital cardiac arrest, had a previous history of lung disease, uncontrolled diabetes, kidney disease, all these kind of things. Basically, the setting is extremely bad. He has a renal failure as well. But the problem is he doesn't have any advance directive or any proxy or person who actually has the power of attorney here. And the next of kin has 2 children. Okay. So after multiple family meetings, the patient children continue to request renal replacement despite the concerns of ICU team that it is not appropriate. Okay. Which of the following is not recommended step to conflict resolution? Okay. Ultimately, always you should be in same page as the family. You should always try to bring them in your line. Okay. So do you agree with this answer here? Are you going to obtain the second medical opinion, or are you will be reviewing with the interdisciplinary hospital committee, or will you be offering the legal counsel or opportunity to transfer to the alternate institution which we won't do it, or will you be actually negotiating it? Which is the best option here? Do you agree with the C? Which is here the answer is again, which is not. Okay. What is the best option? What is the worst option here? See, remember, I try to always look for these knots. Okay. They'll try to, it will not be like in these capital letters always, sometimes you'll be not noticing this knot as well. So you should, at least from all your MRCP or EDIC guidelines state that you will not be offering your legal counsel to the surrogate and make it more complicated. So in this option where there's a conflict between the patient's family and with the treating team, you try to sit to them, talk to them separately if there's multiple attendants and multiple family members. Try to identify where's the lack of communication is and try to involve a liaison officer. At least in our hospital, there's someone called as medical social worker. Okay, so he'll be understanding the layman terms and their difficulties, their social status as well. He'll be calling the other social support as well. Very clear about with the medical futility here before you actually go in against with the wishes of the family. And there is something called as support committee is different from the legal committee. You will not be offering the legal counsel to the surrogates, but if they want to go for the legal counsel, you will be guiding them. Okay, so there's a different, any doubt here? Any doubt? So another scenario, elderly female, extensive past medical history, previous multiple admissions, okay, is approached regarding initiating the comfort care by the palliative care team. Here the conflict is the patient indicates her to desire to pursue comfort care, but the patient's daughter, okay, who is actually a medical power of attorney, specifically denies permission to change the goals of care. Which of the following is the most appropriate step? Do you agree with this answer? There's a clear documentation that the patient has attained her daughter as her medical power of attorney. But at this point of time, patients want to go for comfort care, but the daughter has a differing opinion. Whom will you go with? Anyone?
Patient.
Exactly. Okay. So before I agree with you, but here the point is you need to understand the competency of the patient. So the whole point in designing this question is assessing the competency of the patient. Okay. Is she or he is competent or incompetent? Okay. Competency of the patient is having an intact neurological status, having an ability, intact cognitive ability to take a right decision, which is appropriate with her decision making, with her diagnosis. Okay, that will be attained by your clinical assessment, and maybe you can take an opinion of your neurologist as well in this setting. See, this patient may have an extensive bad background, but as of now, at this point of time in her admission, if at all she is medically competent, for example, she might have had a cardiac arrest in the past, maybe a lot of other features, but here if she is very clear, she is admitted with some other unrelated disease and all, if she is competent, you need to give importance for her competency, which will be superseding her daughter's competency. Okay, but if at all, if she neurologically deteriorates, her daughter's competency will come into the fore. Okay. Again, the principle here is principle of autonomy. Another scenario, unconscious victim of road traffic with blunt injury of abdomen was brought to the ER. In hemorrhagic shock, trauma team want to take him for an emergency lab. Okay, but they could not find any attendants for the informed consent. What would be the best line of action? Do you agree with this option? Will you be waiting for the attendants? Or obviously this is a very simple thing. Okay, other options, if at all the way this question can be complicated is, you have an attendant who will not be agreeing with the trauma team. Okay, and you have two attendants who will be, one of them will be agreeing with the trauma team for emergency surgery, other person will be against it. So this is a more interesting scenario. So here the principle you're asking is, again, the principle of beneficence and non-malfeasance. You have the best interest of the patient in your mind, but the patient, he's not autonomous. He's not competent, where there is no other attendant who is competent to give the decision maker power. So the next person who will be taking the decision will be you. Okay. So in this setting, the best thing to do is apply the principle of beneficence and non-malfeasance. Go for an emergency surgery, which will be saving the patient. But at the same part, you'll be involving the medical admin like superintendent or the other team in the hospital, and you'll be documenting very clearly the reason to go without the informed consent. Okay. Are we clear here? This scenario is different from the scenario where we've seen past, right? This is an emergency scenario where there's no decision-making power. Metastatic malignancy patient in comfort care is being treated with the morphine. Okay, patient-controlled analgesia, but there's no effective pain control. Going up the dose to 20 milligram hour is advised by the pain team, but the pharmacy audit team cautions against the respiratory depression. What is the most appropriate action? Will you be continuing with the 15 mg and will be accepting the pain, or will you be going with midway where you are accepting some pain, but you are not trying to go to a dose where respiratory depression is there? Or will you be accepting the respiratory depression and going for the morphine at 20? Which is the best option? It was given C, but I would like to know what is your option. Anyone?
Complete pain relief and comfort care has to be given.
Yes.
Despite the risk of respiratory depression.
Very good. So what principle are you applying there? What ethical principles are you applying there? What is this doctrine called? See, any decision, you need to go with these 4 principles of ethics in your mind. Okay. Is this an autonomous decision? That means that is the patient competent? Yes. This patient had a metastatic malignancy because this patient is in comfort care. That means that he has clearly given his approval to go with the end of life care, where your goals are to give an adequate pain control, which is the most important thing. And he himself is requesting for the pain. Okay. So there's a principle of autonomy, which is being satisfied here. What is your second principle, beneficence? Are you applying here? Yes. The reason be the high dose of morphine is being actually thought of to be is for benefit of the patient, for the adequate patient. And non-malfeasance, is there anything which in your mind of causing the harm with respiratory depression with this dose? No, you're not basically doing anything maleficent, right? And their social justice or distributive justice doesn't apply. This is called as doctrine of double effect. Okay. What is doctrine of double effect? Doctrine of double effect is a single intervention has 2 effects. Okay, one is a beneficial effect in the form of adequate pain control, but its side effect could be a cause of respiratory depression. In this setting, your pain control is the most important thing. And other principles like beneficence, non-beneficence, and autonomy are also being satisfied here. Okay. Yes. Good. So a couple of last questions. Shekhar has an advanced neurological disease and dependent at nursing home. Is not able to swallow. Okay, continues to have choking episodes. There's an aspiration pneumonia. Right sugars tried but could not be kept, and he is very clear that you should not try again because of the pain. Okay, whereas your consultant, your attending consultant, no, he thinks that the permanent mode like PEG should be kept. Okay, you're about to speak to Mrs. Shekhar, his wife, and the next of the kin about the PEG. And as it is felt that Mr. Andrews does not have the capacity to do the consent. This is the first prerequisite. I have shown you in the algorithm. The first prerequisite is assessing the competency of the patient or capacity to the consent. If that is not satisfied, then only you'll be going to the next of the kin. Okay. Here the medical team has a difference with the family. So what is the best course of action? Again, you need to apply all the principles here. So autonomy is the patient's wife is the next decision maker. What will you do? Have you any one of you read about the hierarchy here, decision making hierarchy? For example, you have a live-in girlfriend and you have a wife which is estranged. Who is the decision making person? Anyone? Just to make it interesting for you. Live-in person or yeah. Okay. Anyone who has okay. Most of the people are with girlfriend, I think. Yes, exactly. The rule says that there should be a documentation that or maybe there's a proof that this patient lives with someone who actually more concerned or more actually within thinking with the patient's decision making power. And if the wife is long estranged or there's an ex-wife or something, no, she'll come into the later part. And for example, if there's a parent, for example, there's a mother who wants to have a different decision and the wife who wants to have a different decision, will the wife comes first or the parent comes first? Anyone? Wife or parent? Yes. Wife comes first than the parents. Okay. So there's a hierarchy, just read about it. And the children comes later on. So there's a hierarchy in it. Okay. And if at all, if there's a clear documentation that the non-relative was clearly documented that he is the advanced medical director, he is the decision-making power, he comes to the first despite having all the relatives. But it was always advised if there's an option of if there's an option no in your answers that you'll be sitting and discussing and coming to the same page with all the relatives, you should opt for that one. Okay. Here you have all the principles like autonomy, beneficence, and maleficence need to be applied in this case. Maybe last one, I think patient admitted in your ICU has a documented allergy to the penicillins. Okay. And it was very clearly told by the doctor in the ear. But unfortunately, the night doctor has given penicillin without noticing the allergy. Had a severe allergic reaction and hospital course was very complicated. So what do you do here? What is the scenario given to you? It is the scenario given to you is medical error. Okay. Bordering on medical negligence as well. Both are different. Okay. If there's a grave mistake and which is causing a life or limb loss, it is called as medical negligence, where just before that one, it is called as medical error. Okay. So what are the three components here? So you'll be asked, you'll be given later options. To cut short to it, your principle of honesty, okay, or veracity. Okay, it is called as principle of honesty or veracity is the key ethical issue which is being addressed here. You should not go around beating around the bush and not address the issue. First thing you should do is address as a team. You will be representing your team member, okay, and you are a representative of entire team. You'll be acknowledging your mistake first. Then you'll be saying sorry or apologize for the mistake. And if at all, if they want to take up this mistake to the next level, you'll be explaining the critical incident reporting system or guide towards the grievance committee. But this step C should not be told to you. It should be asked by the patient's family. Okay. Otherwise, to again, unnecessarily, there will be legal issues. And the principle of honesty is the key issue here. Admitted with a suspected PE, one patient started on medical treatment and was told that she'll be undergoing a CT scan shortly. But unfortunately, the machine was malfunction. But somehow the entire team missed to tell her and no one visited till her on Monday. So this is a scenario of difficult patient or angry patient. What the principles you'll be doing? Again, the same thing. You'll be acknowledging and apologizing for the mistake, and you'll be guiding towards the grievance committee if at all, if it's the required. Again, the principle of honesty is the important one here. Some of the one person has admitted with you with short of no breath. Okay, she was stable and shifted to it. Chest imaging show metastatic malignancy. So basically the protocol you are asking is Spike's protocol. They may be asking individual component based in the Spike's protocol as well. Okay. Suspected PE is the same one, I think. So non-verbal communications, you know, the solar, sit straight, open approach, lean towards the patient, be empathetic and relaxed. Okay, so we'll be finishing here. It's a lengthy topic, but remember, the more you train yourself, more you practice your exam case scenarios, the better it will be easier in your exam. Okay, and I'm an MRCP myself, so this, if you train better for this communications and end of life, no, your life will be easier in the MRCP as well. Okay, so your battle is actually won before you, even if you actually enter the battlefield itself, if you train well. Thank you, and I'm ready to take the questions if you have any.
Thanks, Dr. Sonu Deepak, for your extensive and very elusive presentation. I think one of the best ethics talk I have ever heard.
Thank you. Thank you.
So explanatory. Now, I will give 1 minute for any questions that arise. Otherwise, I'll just go do a quick brief of the course, and then we will finish the session after that.
Yeah, someone has asked if you could send the book. Yeah, we'll be definitely sharing you. I think you can share the mails, this one, no? And the mail we can send it to you. And one thing I can have an appreciation for the audience is this seems to be very interactive and very knowledgeable audience. I think you have a very good chance of clearing the exam in the first attempt.
All right. Thanks, Sonu Deepak again. I'm just going through the course. I would just take 5 minutes to tell what we are doing. So this is a preparatory course for EDIC 2. Me and Dr. Tapas are the director of the course. We have been doing this course for last year. This is the third batch that we are doing with some excellent outcome of it. So I think we had around 80 students enrolled total with about 80% pass, which I think is pretty good for a course, for an exam which is conducted in Europe. Now, to summarize in one page, we know that we have to prepare a lot of things for a critical care exam, and you should not panic. The clue or the secret to pass is to organize and have a structured approach. I know it is very easy to say, difficult to do. So that's what Trics does. It gives a targeted approach. We assess you in each step in the way that we can give some input to you, and then that can be helpful to you. I believe my slides are pretty visible to you guys. This is the course structure that I told about. We have around 30 faculties and mentors combined. Most of them are EDIC, who have passed EDIC and are of international and national repute. The whole course is designed into 10 modules. It says 9, but it's 10 modules.
The slides are not visible. Sorry to interrupt.
Oh, there's some issue with that then. Give me 1 second, please. Just give me 1 second. Is it visible now? Is it visible now?
Yeah,
It's visible now, yeah.
All right, excellent. Sorry, I'm not a tech savvy person, so my apologies. So, as I said, I was describing, it is a comprehensive review of the whole syllabus, and that's what is the target, to organize and make a structured approach to your preparation. That's the structure of the course. We have 10 modules, around 30 faculties and mentors who are very well reputed and well learned. Most of them are EDIC qualified, and that's the total module structure, how it is. We have divided the whole course into 10 sections, and each section will be provided with some pre-reading to the candidates. Then we'll have an online exam that they can take in their convenient time. And the answer sheets will be distributed to them, and they will be marked, and then we'll have a debrief of the whole exam. That will be followed by 3 mock exam. Sorry for this slide error. There is 3 actually. 3 mock exam after completion of the 10th module, which will have the whole syllabus compiled into usual EDIC pattern exam, like CCS and CBS. Also the module, each module will have CCS and CBS exam in it. I talked about the objective of the course already. This is more of a EDIC-based exam, but people who are FNBs or DNBs or in different courses can be benefited with it, because it's the knowledge and the approach to any clinical exam that we share. The debrief are absolutely essential, and they are very, very informative to tackle any sort of super specialty exam in critical care, not only EDIC, but also in any other exam that you can think of. Again, going into the course structure. So once you enroll into the course, then we'll have an introductory meeting with the faculties and the people who have enrolled. Then each module will start on the first day of the module. You'll be provided some pre-reading, but they are not absolute material for EDIC. So you have to have your ACE module finished, and if you want to go to other resources, you're very welcome to. But this pre-reading material will have the landmark articles, some excellent review of each of the topic, which will be easy reading for you guys, which we have compiled. Then after the first week finish on Saturday, you will be given a link for the exam, which is online, and you appear the exam online, and the answer gets submitted. And the next day on Sunday, we'll have the debrief starting at 7 p.m. with the faculties and mentor as assigned for the topic. And we'll go through each of the question, how it should be answered, and what is the mark secured by the candidates in each of those answers. At the end of 10th module, that is after 10 weeks, we'll have 3 more mock exam, which will comprise of all the subjects, like all the modules. All the systems will be included in a pattern of EDIC, and that will give you a more exam-based experience or simulation. The enrollment has started. The course starts on 10th of next month. We aim to have 50 candidates, not more than that, because it's very hard to arrange mock test for 50 candidates more one-to-one with the examiner. So we will probably not be able to manage more than 50 candidates. So I will urge people to enroll if they want to enroll beforehand, before we reach the limit. The track record of ours is very, very good. We haven't missed a class. We haven't missed a debrief in last 3 sessions. Everything happened on time and no complaints about it. The faculties and the coordinator and the mentors have been excellent. Their help is highly appreciated, and we haven't missed a single session in EDIC 2 preparatory course. I talked to you about the reading material, the access you'll get chapter wise each week, and you'll be provided with a link which you can easily access, and all the materials are there. You can read. It's a pre-reading material before you appear the exam, but it's not a substitute to the ACE module, as I said. Then each exam, I described about it. So each exam has CCS and CBS in it. Suppose the first module is cardiothoracic intensive care. In that, you'll have at least 2 CCS and at least 20 CBS questions as per the EDIC syllabus and pattern. And you will be given a debrief of each of the questions, and also we'll discuss the questions surrounding those type of scenarios. Suppose there is an IABP question, we'll be talking about all the scenarios that can be asked in IABP in the debrief. We talked about the debrief already. The mentors are very, very highly skilled, highly reputed people. They help out with the tricks. How do you appear the exam? How do you approach the scenario? They are very, very important to help you to pass the exam. So don't miss the debrief ever, but all the sessions are recorded and you can access retrospectively throughout the whole course. So it's a good way to revise before the exam also. Talked about the mock exam, one-to-one, face-to-face. There will be three mock exams simulating the EDIC pattern. In the roles, so as course faculty, we are very thankful to the faculties who are there. They make their questions. They are very fresh questions, never been asked in any of the exam. They try to cover all the edges and they come to us. It goes for a rigorous check, and then we finalize the question. So they are very, very important. The faculty's input into it. Even the faculties have provided us the reading material before all this. So like the previous courses, the reading material are compiled by the faculties, individual faculties, which is again says that the quality of the material inside those reading material are pretty good. And they have 100% participation in the debrief session. Me and Tapas are the course director, as I described. We start the show, like the first session is by me and Tapas. And there, that's a tradition for us. Each time we have done it. And we are very, very thankful to Dr. Swarna Deepak, who is like absolute gem in our whole team. He does the ethics, the best person I have heard ever. Probably you'll be hearing back from him again, but he's a very, very excellent contributor to the course and gives timely feedback. We are very thankful to him. So as Manjunath, who has attached with us this time onwards with his excellent ideas and input. We are very thankful to them. They managed to have some time and do this presentation today, and the previous one. We are very, very thankful to them. Yeah, so we have guest faculty, which we call as the mentors, like pretty reputed faculties worldwide. So they are very, very helpful. They know the scenario outside India, how the questions are asked and how the questions are put in exams, international exams. I look forward for you guys to join if you want to. You can go to our website 360criticalcare.com. There is a link to register. There are information sheets there. We have provided our contact number. If you have any issue or any information that you need, then feel free to call us. We'll be happy to guide you. Just announcing that we will be starting our first module on 10th of February. So if you are planning to join, then join beforehand to take advantage of the course. The seats are limited, 50 seats, not more than that. We cannot manage because it's a very, very big hassle to arrange all the face-to-face mock exam vivas. So we cannot manage more than 50. So I would request you guys to enroll if you are thinking of. Don't waste time for it. So that's it from my side and from my team here. I'm very thankful to Tapas and Swarna Deepak and Manjunath getting their time here. And if there are no queries from the candidates, then I would say I will finish the session. There are a few questions. I'm just scrolling down. Exam timing. It's so exam timing is not fixed. It is up to you when you want to. The link opens 8 a.m. in the morning on Saturday, and the link closes at 8 p.m. or 7 p.m. on Sunday. So more than 24 hours, the link will stay active till the debrief happens. So whenever you have time on Saturday or Sunday, you can appear the exam. I would recommend to take the exam on a laptop and complete the exam in one go, because that will simulate the exam scenario rather than doing a bit and pieces every 10 minutes of it, every 1 hour apart. So you can appear the exam the whole day Saturday and up to the debrief on Sunday 7 p.m. So the exam, the debrief is fixed. It's on Sunday 7 p.m. each Sunday for 10 weeks. Timing of exam, that's it, sir. I have registered. Then from when will I get the, so 7 days prior to 10th, that will be on 3rd. We will send you the link for the reading material. I just wanted to reiterate again that these are not supplement. These are not the only reading material. They are only supplement to the ACE module. So that's what I would recommend, that don't leave your ACE module, because that is very, very important. These are in addition to cover whatever is not given in the ACE module to make you more prepared. How long will we have access to the videos? So till you appear the exam, and probably after that also, but at least till you appear the exam, you will have access to the current Trics video and also the videos of other master classes that we have in our different courses, but all of them are intensive care based. So that's the query I have. Someone has sent me an email for, okay, that's for I think that's it. I think there's no more query that I need to answer here. Sir, can we get the latest? No, ACE module is not given. That's what Dr. Tapas was saying. You need to enroll into the EDIC course and get the ESICM membership where you will get the ACE course. I will recommend that when you register, you get the membership at the same time because it is a discounted price and you will not get that offer often. If you want to register for ESICM alone, it will cost you more. So just get registered to the ESICM ESICM and the exam at the same time if you are appearing that. But it will be unethical for us to distribute the ACE module, so we cannot do that. It will be a legal liability for us, so we will not do it. If we can't attend the debriefing live, can we access? Yes, that's what I told. All the debriefing videos are uploaded to our YouTube channel, and you can access it after 12 hours because that's the processing time we need to upload that video, because it is a 2-hour or 2.5 hour video. So it will be available next day. All right. If you guys don't have any other questions, then I'll probably finish the session. I'm very thankful to all of you guys who have joined, taken the time, whether you join the course or not, but I will wish you best of luck if you're appearing the EDIC exam. We are happy to help. Even if you are not in the course, you are free to call us in the number if you need any assistance or any sort of guidance. We are happy to if we can, right? We'll look forward, whoever is joining in the course, I look forward to see them in a couple of weeks' time. Thank you. Thanks a lot. Thanks, Dr. Deepak and Dr. Manjunath for your time.
Thank you, Sananta. Thank you, Tapas. Manju.
And
Thank you,
Dr.
everyone.
Tapas, yeah, Dr. Tapas is away. He is busy in some
Thank you
family
all.
commitment. So I'll finish the session here. Thank you all.